Good evening, everyone who has joined, and thank you for having logged in time. Sorry for the short delay. We were waiting just for some more people to join. I think we are ready to start. And indeed, it is a very good evening to every one of you from wherever you are joining us. It is 8 minutes past 7 East African time in Nairobi. And so good afternoon or good evening, wherever you may be. Now, just a minute. My name is Sama Gutu, and I will be your facilitator for this evening with my other colleagues whom I will introduce at the appropriate time. Now, today's session is part of the Teleeducation for Clinicians and Leaders in Africa, TECLA, which is an initiative between Making More Health, together with Ashoka and two social enterprises from Africa, Chronic Drugs Medical Scheme, our CDMS from Kenya, and MDOC from Nigeria. This month, in collaboration with the Hospital Pharmacists Association of Kenya, HOPAC, we are leveraging Project TECLA for patient safety leadership in Africa. Now, this initiative seeks to increase awareness on the impact of patient safety on health outcomes and the general well-being of patients seeking care. Together, CDMS and HOPAC and our other partners are working on, Making More Health, are working on a project with some public referral hospitals to implement patient safety systems in their facilities. Our expectation after this project is to subsequently engage more facilities to go through the same process and thus increase patient safety best practices across the country and indeed across the continent. Now, today's TECLA session is one of the activities commemorating the World Patient Safety Day, and the topic is medication safety, building a patient-centered approach. Our didactic speakers this evening are Dr. Dorothy Ayoak and Dr. Clarice Ambale, whom I will introduce at the appropriate time. We will also have a case presentation during the course of the didactic. Now, we have over 350 participating hospitals from across the continent. In Kenya, we have partnered with the Rural Private Hospitals Association of Kenya and HOPAC, among other partners, whose representatives have joined us this evening. We also have a portfolio of experts, as you can see on your screen. Now, please note that Project TECLA Africa leverages the ECHO model. We collect details of registration, participation, questions and answers, chat comments, and poll responses for our programs. Your individual data will be kept confidential and handled by authorized personnel. This data may be used for reports, maps, communications, surveys, quality assurance, evaluation, research, and to inform new initiatives. This session will be recorded. We will subsequently be sharing a PDF version of the slides after the session. Please avoid using your gadget. Your gadget model as your name. For instance, having iPhone S9 or Oppo A5. For security reasons, please use your real name. Introduce yourself on the chat, giving your name and your organization if you're from a health facility, and state how many people are using your gadget. Please, if you can, please remain muted at all times. And please use the raise hand feature in Zoom when you want to ask a question, or better still, write out your question on the chat. Our technical support team is available to help you on any technological issues, and the contacts of Habil, Robert, Achien, Imelda, and Emily are there on the screen. I'll leave it just for a little while for you to take, those numbers. Now, this session will take 1.5 hours, and you can see the agenda on the screen. Now, at this point, I would like to just introduce the partners. I represent CDMS. We are a Kenyan social enterprise based. We are a Kenyan social enterprise within the Making More Health network, and our area of operation, we use technology to make healthcare more accessible and affordable. Our business model comprises TECLA, which is the program we're running this evening. We're also running a patient safety program, as I've already mentioned, with certain public referral hospitals in Kenya. And we also have TIBANET, which is an e-commerce platform, which is used for group purchasing, targeting small hospitals. I'd like to know if any of our colleagues from MDOC are on the call, Adora or Olabisi. Is anybody from MDOC?
Hi, Sam. Can you hear me?
Yes, I can. Thank you.
Okay, the network is a bit shaky here. I think it's because of the rain. So pardon me that my video is turned off. I'm trying to manage the bandwidth. Welcome, everyone. I'm happy to be here. Like Sam said, MDOC, we are a social enterprise, also part of the Making More Health network, and our work is pretty much around providing self-care support for people with regular and chronic health needs. We're based in Nigeria and looking to also enjoy this important conversation around patient safety. We think that's a very key aspect of the work that we do and the quality of care that we're pushing to achieve. So thank you everyone for joining. Please stay till the end and please participate. We want this as participatory as possible. Thanks, Sam. Over to you.
Thank you very much, Adora. I'd like to know if our partners, Rufa, are on the call at Reverend Kariuki.
Good evening, Sam. You can hear me?
Yes.
Thank you. Good evening, everyone. This is Reverend Joseph Kariuki, the Vice Chair of Rufa. We thank you for today's session. Very important that coinciding with this International Day for Safety. I really appreciate, and on behalf of Rufa, we want to say thank you, and we'll be following to gain more knowledge on the subject for the day. For all our members and our partners, karibu sana, and God bless you as we move on. Thank you.
It is now my pleasure to introduce our didactic speakers of the evening, Dr. Dorothy Ayuak and Dr. Clarice Ambale. Dr. Ayuak is a pharmacoepidemiologist based at the Kenyatta National Hospital in Nairobi. She has about 20 years experience in pharmacy practice. She holds a Bachelor of Pharmacy and Master of Pharmacy in Pharmacoepidemiology and Pharmacovigilance from the University of Nairobi. She is a member of several professional associations that include the Pharmaceutical Society of Kenya, International Society of Pharmacovigilance, and the International Pharmaceutical Federation, FIP. She currently also serves as the Secretary of the Hospital Pharmacists Association of Kenya, HOPAC. Now, Dr. Ayuak is also the Secretary to the Antimicrobial Stewardship Committee, among other responsibilities in multidisciplinary teams. She is passionate about building a patient safety culture among other healthcare professionals through facilitating various training programs and also about training and mentorship. as you can, and we are really honored to have her today. Our other speaker is Dr. Clarice Ambale. Dr. Clarice Ambale is also a pharmacoepidemiologist and health systems, and also a health system strengthening expert. She has over a decade's experience in hospital pharmacy practice and has a passion for ensuring the safe and efficacious use of pharmaceutical commodities, and enjoys sharing this knowledge via continuous medical education sessions like the ones we have today. She's an active member of HOPAC, where she's currently serving as an elected national committee member. She's also a member of the Pharmaceutical Society of Kenya, PSK, the International Society of Pharmacovigilance, ISOP, and the International Society of Pharmacoepidemiology, ISPE. Their presentation will take, and case study will take 40 minutes. I would like to welcome Dr. Ayuak and Dr. Ambale to give us their didactic. Karibuni.
Thank you very much, Sam, for that very kind introduction. I want to hope that I am audible, and as I share my screen, you'll confirm that you can actually see the screen displayed in a slideshow. Please confirm.
Yes, it is.
Okay. So thank you very much once again for today's session. I need to start with the element of risk that with schools having closed, I'm struggling with some background sound. So I'm hoping that I'm going to be audible all through. So I hope it is not going to be too much, but I'm glad that we are running this presentation with Clarice. So as to manage this, the bandwidth, I will keep stopping to share my video so that now the the presentation just moves on smoothly. So thank you once again, and thank you to all who have joined us today as we are preparing to celebrate the World Patient Safety Day. I hope my screen is clear all through. Yeah. So we are going to look at building a patient-centered approach, and this is just as we are preparing to commemorate the World Patient Safety Day. That is actually going to be on the 17th, but there are a lot of activities around the date today. So as we start, just a little highlight on what World Patient Safety Day is focused on. There are these four main objectives, and today we are hoping that we are going to also be part of the team that is raising the awareness on the burden of medication-related harm. And I'm hoping that we are going to convince you to also support the efforts to advocate for urgent action when it comes to improving medication safety. I believe you are stakeholders in the area of patient safety and medication safety, which is the theme for the year. And we can be able to engage together to see what we can do to prevent medication errors and even reduce the error-related harm. I'm hoping that we'll also be able to empower our patients and families to be actively involved. So we are going to follow this schema for our presentation today. So to start off, you'll be hearing medication safety, patient safety. So you'll be hearing us talking about medication safety and patient safety interchangeably. So just to have an idea, what is patient safety? This is basically everything around how we do work, what we use to do work, the environment around which we do work, and how we ensure that we can consistently and sustainably lower the risk, or if we have a system such that it is less likely for errors to occur, and in the event that they do occur, then the impact of harm is reduced. Then when we go looking at medication safety, it is one of the questions on the pop quiz. Medication safety, as defined by the ASHP, is a freedom from accidental injury due to medical care or medical errors during the medication use process. I believe you know the medicine use process, the prescribing, administration, the dispensing, transcribing, all that. So why are we concerned about medication errors? We appreciate that now from the reports where the quantification of the harm, the burden of harm has been done, is that it's noted that medication harm accounts for half of all the preventable harm in medical care. So if we just tackle this, we have already taken care of half the problems in our healthcare system. Then when you look at the burden in terms of the financial implication, it is costed at $42 billion US. That's quite a lot of funding that can go into other operations within healthcare team. So we are hoping that you're going to join the efforts of the World Patient Safety Day, which is moving under the banner Medication Without Harm. And the slogan that we are running with, the call to action is know, check, ask. So where did the interest for medication safety come from? There's this landmark report. I hope a number of you are familiar with it. It is from the Institute of Medicine that was published in 2000. It's called To Err is Human. I believe we have had these statements a lot, that it is, we are human, we are prone to error. So in this report, it highlighted that for every hospitalized patient, they are likely to experience at least one medical error in a day. And when we look at the medical errors, you find 25% of them can be prevented. So in this report, it emphasized that we need to design systems in such a way that it will become hard to do the wrong thing and easy to do the right thing. So following closely on the heel came the Joint Commission International, and every year they give the patient safety goals that we, as institutions, especially those which are JCI accredited, and even those which are not, but can aspire to also have these patient safety goals in place. So they give us goals to be able to see how we can focus on the healthcare safety issues and how to solve them. So these goals are 7, as listed on the screen. But our presentation today is going to be focused on the 3 that are highlighted: identifying your patient correctly, using medicine safely, and identifying the patient safety risk. But that doesn't mean that you cannot have systems in place for all the other 4 that we will not focus on today. So I wish to hand over to my colleague, Clarice, who is going to take over and tell us about the key action areas in medication without harm. Karibu, Clarice.
Good evening, everyone, and thank you, Dorothy, for through the first section of the slides, and then Dorothy will come in again. Errors are likely to happen, but errors are likely to happen in certain situations more than others. And WHO has identified the key action areas during which errors are likely to occur. And these are during transition of care, when patients are being transitioned from one form of care to another, for example, being discharged from inpatient care to outpatient care, or maybe moving from intensive care unit to general ward. There's a likelihood of errors to happen in this scenario. And also in high-risk situations, maybe patients taking medicine that have a very narrow therapeutic index, errors are also likely to happen. And also in polypharmacy, where we are talking about patients who are taking either 5 or more drugs at this, in one day for different comorbidities. Errors are also likely to happen for such patients. So what then are we supposed to do, and what actions can we take for different stakeholders? Starting with us, the healthcare workers, what do we need to do? We need to get adequate education and training to identify medication errors. We need to learn about medication safety and what we need to do in our various areas of service delivery. We also need to communicate adequately amongst ourselves and have teamwork, because sometimes errors happen because of poor communication, transcription errors, prescribing errors, poor handing over procedures, and this can be effectively reduced or even eliminated if there is communication and proper teamwork. We need to be capable of doing our work at our point of care. So we need to be capacity built, and we also need to report incidents as they occur. We need to know that incidents are reported so that we can be able to monitor how patient safety is being ensured at our service areas, and also for learning purposes, to be able to know how to prevent this from occurring in the future. And Dorothy will later talk about just culture to just reassure healthcare workers that reporting is not supposed to victimize the healthcare worker who has reported an incident of medication error or an incident that led to medication harm. Next slide, please. Medicines themselves can lead to medication harm occurring, and as healthcare workers, we need to ensure that we are using medicines that are of good quality and are safe for our patients. When procuring medicine, let's ensure that we procure from distributors or manufacturers that are regulated by the National Regulatory Authority, that is the Pharmacy and Poisons Board. They have marketing authorization holders. And also we check the products to ensure that they are safe and of quality. Let us check our fluids to ensure that they don't have particles. If they're supposed to be clear, let them be clear. Let's check our tablets to ensure that they don't have molds developing on them. And also that the consistency is good as recommended. If we administer poor quality medicine, they can lead to medication harm, medication-related harm. Our products should also be named and labeled correctly. We've had cases of products that are looking alike, the packaging and also the color that have been used. This can lead to errors because of mix-up of the drug. So let's ensure that we have labeled our products well to prevent such errors from occurring, which can eventually lead to occurrence of medication harm. How do we store our products, especially for the cold chain products? If the temperature is not as per the recommendation of the manufacturer, then we might be administering drugs that are not potent. And this can also lead to harm to the patient and therapeutic ineffectiveness, which can prolong the duration of the condition. Let us have the right products at the point of care as we serve our clients. We should not be rushing to order products for the emergency tray when we have a situation at the A&E department. They should already be there so that we don't just use what is available, but we use the right product for that condition the patient is presenting with. Next slide. The systems in our facilities need to support the practice of medication safety. Let us have our leaders support this. Let us have their buy-in and goodwill in advocating for medication safety. We need to have guidelines that guide the healthcare workers on how to prescribe, how to dispense, how to prepare extemporaneous preparations. We have teaching institutions where we work, and we have interns and even students who help us do our work even as they learn. Yes, we teach them as through on-job training or DT, but then do we have outlined standard operating procedures that they can follow in case they are working without or with minimal supervision to prevent errors from occurring? We need to ensure that systems are put in place to support this and also guide healthcare workers and even those in training on how to prescribe, prepare, and dispense medication and even administer the same to our client. Monitoring of occurrence of medication harm is also important so that we know where we are and what we can do to be where we are required to be as a facility in terms of reducing medication harm. So monitoring is important as we deliver our services so that we can ensure that we are having the desired outcomes for our patients. Next slide. Patients and the public are also key stakeholders in ensuring that we reduce medication harm from occurring. And we can do this by educating our clients. Let us have medication literacy sessions with our patients. Let us engage them. Let them know why they're taking the medication, for what conditions, and in the eventuality of a side effect, what should they do? And let them also know that they can actually report these adverse outcomes directly to the Pharmacy and Poisons Board through the pharmacovigilance portal. I believe most of us have interacted with the portal. There's a section for healthcare workers to log in and report, and there's also a section for the public to log in and report. They don't have to register. They can just log in directly and report an occurrence of a medication error, suspected adverse drug reaction, or even a reaction to a medical device. So let us involve our patients and engage them and let them know that they can actually report these incidents, and let them be aware of any side effects associated with the medication they are taking and what they can do. And if we have patients who have chronic diseases, I'm sure some of them have patient organizations that we can engage and utilize those channels to educate the patients and empower them with knowledge to help us reduce occurrence of medication harm. So we need to look at the steps that we can take to ensure medication safety. And I'll just request us to interact. Let us chat and say what we can do at our levels of practice to reduce medication harm. What can we do to ensure medication safety? I know we have different cadres in the webinar. I saw we have pharmacists, we have nurses, we have clinical officers, we even have participants from research organizations. So at your level of practice, what can you do to ensure medication safety? Dorothy, kindly help me monitor the chat to see if we have any responses.
Thank you. Maybe as we give people time to respond, we can proceed. I'll raise you when there's a response.
Okay, so let's keep thinking about what we can do at our different levels of practice to ensure we reduce medication harm and maintain the safety of our patients. So we'll go through these steps with the help of a case study. We'll look at the case of Mrs. Polly. Mrs. Polly is a 65-year-old woman who lives in the countryside and practices subsistence farming. She presented in the clinic today with the complaints of abdominal pain, dark stools, and fatigue. 3 weeks ago, she was admitted in the hospital complaining of muscle pain because of her farming activities. And 5 years ago, she was admitted again with a heart attack, which was managed, and she is now on the medication displayed on the screen. She's on aspirin for prevention of occurrence of another myocardial infarction. She was also given diclofenac, that is 3 weeks ago when she presented with muscle pain. So the non-steroidal anti-inflammatory agent was for the muscle pain. The rest of the drugs are for her chronic condition and also for her heart condition. So Mrs. Polly came back to the clinic today with the above complaints. Next slide. So on reviewing the patient, the clinician discovered that Mrs. Polly was having a bleeding peptic ulcer due to the NSAID, which is diclofenac. And diclofenac was discontinued, and omeprazole, which is a proton pump inhibitor, was prescribed for her peptic ulcer. They were sent to collect the medicines, I believe, at the pharmacy. And Mrs. Polly, being an old woman and with comorbid condition, she was accompanied by her son. The son went to collect the medicines, and the medicines were dispensed as follows. Of course, the medicines for chronic illness were dispensed, and also diclofenac and omeprazole, which was a new prescription for her. When they got home, the son gave Mrs. Polly the medicines to take. And she noticed that there was an extra medication apart from her routine medicines and also the diclofenac that she was taking previously. And Mrs. Polly was a bit confused, could not remember what the doctor said about the additional medicine and also about the NSAID. So to be on the safe side, the son decided, you know what, ma'am, I don't know which drug is for what. So you are better off just taking all the medicines, because you don't know if the one we'll be leaving out is the one for your heart condition or the one for your cholesterol or is the one for your pain. So Mrs. Polly continued taking all the medicines as dispensed for another 1 week. And 1 week later, they were back in the hospital with the same complaint, abdominal pain and darkening of stools. So on reviewing the patient, the clinician discovered that the NSAID was mistakenly dispensed. There was a breakdown in communication, most likely, between the prescriber and the person responsible for dispensing. Let me assume it's the pharmacist. The pharmacist dispensed all the medicines as per the prescription and did not have a chance to confirm this with the prescriber, and hence the error occurred and Mrs. Polly was mistakenly dispensed for the NSAID, which continued to cause harm, and she was forced to come back to hospital for management of the medication-related harm. Next slide. So these are the steps we need to take when handling our patients to ensure that we maintain medication safety and prevent harm. And we keep referring to Mrs. Polly's case, which is our case study today. We need to ensure that we prescribe appropriately and conduct a risk assessment that will ensure that we have a risk-benefit analysis of each medicine to know if we really require that medicine for the patient and if the benefits of this medicine outweigh the risks that are associated with it. For Mrs. Polly, she had a high risk. It was a high-risk situation that required the healthcare professionals to prescribe responsibly after analyzing the risks and benefits. Remember, Mrs. Polly has a heart condition, and the NSAID being prescribed, apart from causing gastrointestinal bleeding, could have worsened her heart condition. So reviewing the patient and assessing risk versus the benefit of the drug is quite important when prescribing medication to reduce medication harm. We need to review medication as the second step of ensuring medication safety. And this is a multidisciplinary activity. Again, you look at the risk and the benefits of each medicine that the patient is receiving, and also make decisions about future therapy. In this case, you will be ensuring that you enhance the benefits of the medicine and reduce harm. And when the client came back, after developing abdominal pain and darkening of stools, this was actually done. The clinician reviewed the drugs and confirmed that the client had suffered medication harm because of the NSAID. And he did the right thing and prescribed the NSAID. However, an error again occurred at the dispensing point because of miscommunication between the prescriber and the dispenser. It could have been a prescribing error or a transcribing error. We don't know, but the error occurred. So review of medication is important so as to ensure that we enhance the benefits of the medication being given and reduce harm. The next step is about dispensing and administration of medicine. For Mrs. Polly's case, dispensing happened and administration happened for the NSAID, which continued to cause harm for Mrs. Polly. And significant harm in this case because the harm led her to visit the hospital twice. So when dispensing medication, we also need to ensure that we communicate amongst ourselves to confirm that the prescription being, the dispensing being done for the patient is actually what was prescribed. And if you're not sure, please consult the prescriber instead of being in a hurry to clear the queue in some cases, and you end up dispensing a drug that was not supposed to be dispensed, which can lead to medication harm, as in the case of Mrs. Polly. The next step is about communication and patient engagement. We realize that if there was proper communication, number one, amongst the healthcare workers, then this error will not have occurred. And also, if there was communication between the healthcare workers and the patient, and in this case, the prescriber, Mrs. Polly would have been aware that one of her medication, and which in this case was the pain medication, was stopped. Yeah, and at the point of dispensing, she could have reminded the healthcare worker dispensing that the clinician has informed me that the medication for pain, even if she doesn't know the name, has been stopped because of it caused abdominal pain and darkening of stool. That is through the peptic ulcer. So communication is important amongst healthcare workers, and even between the healthcare worker and the patient. It can help reduce occurrence of medication errors. The final step, before we move to the final step, we need to apply medication use counseling in different scenarios. Away from Mrs. Polly's case, we need to apply counseling for use of devices, especially, and also when dispensing pessaries and suppositories. I don't know if we've ever asked our patients to demonstrate to us how they use their devices, especially the inhalers and the inhalers. As you can see, the beautiful lady in our photo is spraying her inhaler on her neck. Probably that's what she thought was the right process of using her inhaler. And maybe the person dispensing to her did not take time to demonstrate how to use an inhaler. And she decided the best way to do this is spray around my neck, probably to penetrate and get to my lungs somehow. So we need to ensure that we do, we communicate to our patients, engage them, and demonstrate where applicable on how to use devices. And if possible, ask them to do it like a teach back. Show me what I've just shown you so that I'm sure you know how to use the device. Tell me what I've told you about a medication, but I'm sure that you understand how to use a medication, and remind them to come back to you in case of any side effects, in case of any adverse effects, and they can also still report on the portal. And then the final step, medication reconciliation, which just involves healthcare professionals partnering with patients to ensure that they have accurate and complete information on medication. This information has to move from the healthcare worker to the patient. So the healthcare worker has the responsibility of reconciling this information with the patient and ensure that they understand, especially during transition of care. So I'll finish my section of presentation with the 5 moments for medication safety. And it applies both to the healthcare worker and to the patient. When starting a medication for your patient, you need to ensure that the patient understands what the medication is for, and also the potential side effects for the medication. They need to know how they should take the medication. They also need to know when we're adding a medication to their regimen and how it may interact with other medication they're taking. If they need to stagger the times between which they're taking the medication, please let them know that. If you're when you're reviewing medication, let the patient understand if they need to continue taking the medication for a little longer, or if they'll take the medication for life, for some chronic condition. If stopping a medication, then you need to know, ensure that your patient understands why you are stopping the medication. And if there are any side effects, you report the same to the Pharmacy and Poisons Board, and also encourage your patient to do the reporting where possible. I'll now hand over to Dorothy to take us through the next couple of slides. Over to you, Dorothy.
Thank you very much, Clarice, for that presentation. And just looking quickly at the chat, I see we asked to say if there's anything that you'd have done differently, so that we encourage you to say that. I see Melda has said, as a pharmacist, I would counter check a patient's drug and check for drug interaction. So please let us know what you do when it comes to the error, if it was the case for Mrs. Polly, or just what you can do about the key steps of patient safety. So now, when we're looking at the just culture in patient safety, we ask ourselves, what do you do when things go wrong? Because we know things will definitely go wrong at one point or another, and we are not immune to the same. So we start by defining the first step, just culture. Just culture is just a system where there's shared accountability. The institution where you're practicing or you're an administrator also holds responsibility for the systems that they have designed. Because remember, medication errors, they tend to happen because of the systems in which we are performing the work in, as well as human-related factors. So we need to have a shared accountability for the systems that are in place, and also the same institutions need to be able to have a way to respond to the behaviors of their employees in a just and fair manner. Meaning that when there is an event, that we don't victimize the staff, but we look through to identify what are the system vulnerabilities. What made the error happen? What is it that is weak in our system that made the error happen? And the employees themselves, we need to also, as healthcare workers, be accountable for our choices. When you notice an error, when you notice a gap, let's also be vigilant and consider it important to report these incidences so that now we can avoid significant patient harm. And when you're looking at the just culture, it takes care of all the factors that contribute to an incident, whether it is a human-related error or it's the environment you work in, it is very noisy, so it is difficult to hear patient alarm, or there are technical challenges. So anything that goes into the how and the where and the what we used to do the work is considered when you're looking at the just culture. So I just want to remind us a few of the incidents when we don't use a just culture, or when we are not keen to identify system issues that can bring up errors, then you end up finding we have medication incidents that unfortunately, when it is picked up by the media, it could be highlighted in a very negative light that makes the healthcare worker either very demoralized or punished for such incidents without reviewing what would be the reason for the same. Like an example of these incidents which happened in an Indianapolis hospital, where because of a mix-up of the drug heparin and Heplock. Now heparin was given instead of Heplock to flush the line, and these products were looking very similar. One was dark blue, another baby blue. I don't know how many people are very good at distinguishing colors. You can just say, especially in our institutions where we have a lot of trainees, or even you're not too familiar with the product, say, pick that blue medicine. So now the description of our products can give a problem. Then just closer to home, because I believe we have quite a large audience that is from Kenya. There is the incidence of the Busia County Hospital, where 28 children they had gone to be treated for malaria, and they say they received an injection for malaria, but then they ended up with paralysis. And there's a lot of media attention around this, and I'm pretty sure the healthcare workers were vilified for the same. But we need to ask ourselves, what was it about the facility, the systems in place? Is it the proper labeling? What is it about that facility that made it made the healthcare worker prone to be able to end up having such a medication error? And it's not only limited to the medicines. You could also have an error when it comes to procedures, because I believe we are a multidisciplinary team in this meeting. So you can have an error with medicine, you can have an error even with procedures. And sometimes when now this happens and we don't have a just culture within our facilities, we say things now go to the dogs, where the healthcare worker is painted in a very negative light, and we end up being defensive. But instead, what we need to do is identify what went wrong and do something about it. So among the patient safety goals that we said we'll highlight in the context of this year's theme is we need to be able to have systems to correctly identify our patients. If I think close to the institution where I am working in Nairobi, we have a number of patients who have shared names, and it comes from the culture where you name somebody your mother, you name them your sister. So you have a lot of people with shared names, even within families. And therefore, if you don't have an additional patient identifier, you're likely to even give medicine to the wrong patient. You're likely to take the wrong patient to give a procedure to the wrong patient. So we also need to think about the workload. Have we adequately staffed our institutions or our workplaces such that the staff is not overwhelmed and they end up mixing up? Then we look at now goal number 3, using the medicines correctly. Besides the point of dispensing, we also sometimes have to prepare medicines before a procedure. You could be preparing the medicines which are on the emergency tray before theater, and you need to ask yourself, can you actually read the writing on most of these ampules and syringes? So we need to be able to have a way to make sure we have added legible, or whether it's using stickers or what it is that you can be able to find tagging or using a marker pen to be able to differentiate medicine, so that when you're in an emergency situation, you're not stuck and picking adrenaline instead of atropine or vice versa. For institutions which do chemotherapy admixture, you probably are doing the admixture in one area and it'll be taken to the ward. You might be having a central unit to do your admixture, and then now the medicine is taken to the ward. Is it clearly labeled? That is also key when it comes to using medicine correctly. When we are compounding tablets, we know it is a tablet. Now, if you did not adequately label it before you started compounding, once you crush it, are you going to be able to identify it and label it properly before you dispense it? When it comes to vaccination, you may need to give us a series of vaccines to a single patient. Have you actually checked what it needs to be reconstituted, what needs to be given in the deltoid, whether they need to be given together, whether it was supposed to be oral or injectable? Yeah? And then we consider that before we give the medicine. And the last goal that we're going to look at is to identify what are the patient safety risks within our institution. I'll give an example of this that we highlighted in my institution, the Kenyatta National Hospital, where we noted that we're having a lot of similar sounding names. And this tends to happen, especially if you have to get your procurement through a central agency, or it is you have no control over how the products look like, because a number of times we just will procure what has already been registered, and we depend on the regulatory bodies to ensure that the labeling is done well. But now you have a scenario where you have this give on the right of the screen. You have 3 eye drops, which the packs look very similar. It's not a black and white picture. It looks almost gray. But now all this, none of them was black. So telling somebody pick the one that is, you can't say off black. It's a bit grayish. So will you pick latanoprost, which should be a fridge item, ketorolac, or atropine? You can imagine if you put the wrong eye drop in the patient's eye. Then these other at theater, you'd find them in our theater. We have diazepam, we have neostigmine, and we have furosemide, and they all look very much alike. The same happens also with oral medicines. So we need to have distinguishing features. And when we don't have that, then we restructure our systems so that you can be able to deal with them, work with what it is you have. So in our situation, we made sure we have look-alike, sound-alike labels so that they can act as a trigger for our staff to be able to note that they need to counter-check, double-check what they're dispensing or what they're about to administer before they give it to the patient. So as I get to the end, I'm hoping that you have taken these messages with you, that we need to be able to keep our practice up to date, find out what is new in the area of medication safety, familiarize ourselves with the 5 moments of medication safety. And I hope that with the case study that you have seen how you can actually apply these medication safety moments. Also, well, just following with the campaign of this year, Know, Check, Ask, and at the end I'll play a short video on the same. You need to be able to know, encourage patients to know what they are taking, check if it is the right thing, and ask any question. When it comes to when you're relating with all the other members of the clinical team, let's be keen to provide clear and full medication-related information so that we don't have guesswork within our facilities. And in the event that there's an incident, I hope you're encouraged that you're going to report it, not as a punitive mechanism, but as a way to improve. And we to know that there are situations where medication, the risk for medication is high. And in these areas, we need to identify this to put in place systems so that now you can reduce the risk of harm. And should harm happen, then you can make sure that at least you reduce the effect of that harm on our patients. And I think for those who are training, or even as we have new members of staff joining us, or even in reorganizations of our various units, take time to mentor the new members on the safe medication practices within the unit. So this is what we are hoping that we are going to be part of the same campaign. When we're talking to the patient, when we're going to give them medication, let's encourage them to know what the medication is and remind them that they have the right to check. And we need ourselves to also check that we are talking to the right patient, giving them the right medicine, you're telling them to use it the right route. And here I'd want to emphasize that besides inhalers, let's think about how do we dispense pessaries, suppositories? Do we give clear information on how this is done? Then also confirm, does your patient actually understand what you've told them? And the same campaign, we take it to the patients to tell them they should not be scared to know what exactly they are taking, and check that they know the right dose and the time they should take it. And when they have a problem or when they don't understand, they should be able to feel confident enough to ask you to clarify. So this year, we want to ask now if you can think just of what you can do yourself as an individual, as an institution. We want to give just a few ideas. You can either have a medication safety improvement project. For example, you can look through your organization. If you're a number of you from the same institution, just think about what is your priority medication safety issue. And if you do have medication safety champions, this could be a good time for you to actually acknowledge them and recognize their efforts. If you have any way of awarding them, just to be able to give them a pat of the back and encourage them to continue with the systems and following up to make sure that you have a safe system. There's an ongoing campaign, and I hope you'll be able to join it on Twitter, on LinkedIn, on Facebook, with regarding the theme of this year, medication without harm, no, check, ask. And I want to encourage us to be part of that campaign and get this message out. So those are the references we've used. And as you think through the questions that you want to ask, I will play a short video on the same. So if there are questions, you will confirm to us, Imelda, if there are questions on the chat. Okay, so I think now you can be able to, there's Evans. Okay, so I believe Sam, you can be able to run the Q&A.
I'm here.
Are you going to, Dr. Dorothy, are you going to play the video?
Yes, we can play the video as we wait for the questions and answers. Right. The questions. So I want to verify that you can actually see the video projected on the screen. Is that so?
Yes, we can see it.
Okay. No, so yes, okay, so thank you. So I will take it back to you, Sam, or is it Imelda who is going to be running the Q&A?
Well, thank you very much, Dr. Dorothy Ayuak and Dr. Clarice Ambale, We really, really appreciate the insights that you have given all of us on medication safety. And now it is time for us to take your questions. I believe there are questions that have been raised already on the chat. Imelda, Emily, Isaac, just please advise on the questions that have been asked, please.
Thank you, Sam. The first question you've received, I'll ask both Dr. Clarice and Dr. Iwak. What sites or references will you recommend for checking drug-drug interactions?
Okay, I'll give an example of one. I know there's the Medscape, there's the Medicine Complete, but Clarice can add others.
I'm familiar with Medscape also, and it's quite reliable. So I can advise that we can use Medscape for checking drug interactions.
Okay, thank you. I hope you've noted the sources. There's another question that we've received from a pharmacist. They say that they've noticed in prescriptions that most medical errors are from prescribers. How can we bridge the gap between pharmacists, doctors, and nurses for medications to increase medication safety?
Thank you very much, Imelda, for that question. I usually feel for my clinician colleagues, because you see, for the doctors, the medical practitioners, the clinicians, when they make a mistake, it's almost like an architect. It is out there to be displayed. Because they have written it down, it is easier to identify, and therefore it gives us the sense of thinking that most of the errors are prescribing errors. But for dispensing and administration, for you to note them, you have to actually observe them. It will not be documented anywhere how you dispensed. It has to be an observation that is picked up. So I would say it gives us a false sense that majority of yes, we do document majority of errors as prescribing errors because they are written down, but there are a lot of dispensing errors and administration errors that go undocumented because they are observed. So what we can do still, because we have data on prescribing, continue talking to our prescribers, but also to encourage ourselves to also document when we have made errors so that others can learn that I have ever made a dispensing error of a lookalike, and therefore you caution those others in your teams to do the same. Clarice, do you have something additional to add?
Yes, I'd say communication and teamwork will help, because you need to work as a team. And also you need to document the errors. So you're saying most of the errors are made by prescribers, but do you have any data to show that? So in case you have data, then it's good to have a roundtable discussion and agree on what needs to be done to avoid the errors from occurring and what channels should be followed without victimizing or pointing fingers. You shouldn't look like you're policing your colleagues. But once you identify that the errors are actually there and it's documented, then it gives you a platform to now say, we have this data that errors occurred at the prescribing or dispensing level, and to mitigate this is what we are recommending and agree as a team. Thank you.
Thank you, doctors. I can see there's someone named Evans Majune who has raised their hand. Would you like to ask the question verbally? Please unmute yourself. While they continue unmuting, there's someone who's asked, can you share with us how to draw the chart for drug safety at the dispenser or pharmacy? Evans Majune?
Yes, I believe you can hear me now.
Yes, go ahead.
Yeah, my name is Evans. I'm calling you from West Side. Yeah, I think it's a nice eye opener for us. I didn't know there is an international medicine safety day coming tomorrow. So I think one, we've learned that there's something that is caring about patient safety within our country and within the world. And it's also close to us as a facility. My question goes to, I think the problem we have mostly is the reporting mechanisms. I know the PPB has opened up a portal where we are able to report, but we are not sure of how do those report benefit. I remember seeing, I think a packaging of azithromycin. There are supposed to be 3 tablets, but we got 2. So we sent that to them, but up to today, that was 2018 or 2019 thereabout, up to today, no response. We saw dextrose 5% that had some moles in it. We reported, but so far nothing has, nobody has even bothered to say, hi, what happened to that solution? What have you done? So I think that even as the management, we need to see how do we respond to the facilities? You know, when you raise such issues and nobody is trying to address them, people tend to give up and say, well, when we get maybe a major problem, yes, the media will highlight, but what of these small issues that come about with either medication safety or with the, apart from just the prescription errors that we've noted, how are we going to be supported? Even maybe the private sector and even the public sector can come together and fight for the same goal. Thank you.
Thank you very much, Evans, for that comment, for that observation. And indeed, you're right that it can get very frustrating when you institute a reporting system and you feel like nothing is coming out of it, especially when you are relying on another party to be able to get the solution for you. And in this case, it's a regulatory agency. What we found in our institution that works with to just have a system for being able to internally handle the issue. So when we find a product that is having quality concerns, we have systems within to be able to recall the medicine and liaise with the supplier and our supply chain department to have it tested and check what is the problem we get documented evidence of what is wrong with the product, and then we can be able to issue rejection notes and look for an alternative. Now, what would encourage is within your institution, if you can be able to come up with internal mechanisms so that now, if it is, we say serikali imechelewa or the government is taking a while, there are our government organizations, but we do hope that some of them are following us today and will take it up to actually do something about the issues that we raise. We appreciate there are times when they have actually been the ones who are proactive, but I know we still believe we need to see a bit more. I'm seeing the other additional references that have been given.
Maybe before you conclude, I just wanted a clarification. When you get such issues, do you set aside the entire batch numbers, or do you set aside the only batch that is affected? I don't know. How would you advise? Maybe, especially when we saw the dextrose 10% that had moles in it. What are you supposed to do? The other bottles seem to be okay, but this one has got a particular problem.
In our situation, the first thing we do is issue a notice that they need to put aside the product. And then we check. We had an incident of mold in some bottles of injection, but now later we realize sometimes the nurses, when they are withdrawing, reconstituting medicine, they can pick a bottle and just, you will not see the point where they injected, and just withdraw a small volume. And then because the bottle still looks almost full, somebody might accidentally pick it up and return it back to the shelf. So when you find it is only affecting a small batch, you need to ask yourself, which unit has anybody else encountered the same problems, that you'll work case by case. But our first response is fast.
It was okay. It was applied in a box. So when we are opening now the boxes, just to check for the utilization, then it's when we found one in the middle or somewhere in between. that had mold. So we were just wondering now in such a situation, this one was not the one that was already in use. It's the one that you are just opening up and you find, oh, there's a problem with this one. What do you set aside the entire consignment? Do you set aside the only affected ones, or what would you advise?
Because it's a high risk product,
Yes,
we would prefer to err on the side of caution, where you set aside the entire batch.
Okay, so another question for us, private sector, how do you return it, the entire package to the pharmacy that supplied, or do you sometimes, I don't know, okay. The cost implication of that is what I'm wondering. How is it going to be covered?
I would say, okay, maybe we might have to take that conversation offline, but we usually find it's easier when you report it and you have we have the backing of the regulatory authority when you need to, because there's a financial implication when you have the backing of the regulatory authority to have the whole product recalled. But I would encourage you to sit with your institution and you come up with systems, you come up with SOPs, what is your plan? And then you also sensitize those who are your suppliers that in the event that we note a quality concern, this is what we are going to do. We're going to return the whole product to you because we don't want to take chances. So some of these are, you'll have to come up with institutional interventions.
All right.
Okay. Okay, thank you, everyone. I think we've learned something. CDMS and HOPAC, I think we need to take another session to talk about pharmacovigilance sensitization. I think that's a rampant question. I have to mention Kevin and Dr. Nath Ara, who have recommended sites where you can check drug-drug interactions, including Micromedex, Tolman, and Lexicom. Please look at the chat if you need further questions. And then Kevin has said, please contact anyone from MTRH to find out how you can get an account. So there's someone who has asked, has anyone come across a study that could guide us on pharmacy prescriptions ratio that would be ideal? I have not understood that question. Has anyone come across a study that could guide us on pharmacy prescriptions ratio that would be ideal?
I think Clarice can take, but I want to believe what Anne is asking is, do we know the ratio of how many prescriptions should a pharmacy handle in a day? What is the ratio? Do you work on 30 in a day? Is that the workload? I want to believe that is related to the aspect of what is the workload, and now a heavy workload contributing to prescribing, dispensing errors. So that might be what she's asking of what is ideal. So Clarice, are you able to take that?
Yeah, I think that's what she's asking, but then I don't think we have that already in Kenya. A guideline showing the ratio of pharmacists to patients, maybe not prescription, because a patient could have several prescriptions, I believe. So it's not yet clear on what the government recommends should be the pharmacy patient ratio. It should be pharmacy patient, not really prescription. So we wait for the Ministry of Health to give that guideline. Thank you.
Okay. Just to add, Anne, you could consider in your institution, look at the workload and see, estimate how much time do you expect to handle one prescription. In my institution, we said we expect that one person in a day should be able to process 30 prescriptions without much of as that being as workload to guide how many people you need to deploy to an area. So you can look at the kind of prescription, the kind of patients you have. We are specialized healthcare facility, so we tend to have very long prescriptions or complex ones. So now that is what guided the number that you should serve in a day. But you can also look at your institution.
10 minutes late, so we also extended.
Okay, Sam.
Thank you.
Okay, so there's a question from Elizabeth about SOP. So I want to believe you're asking, how do we outline, whether you're asking, I need clarity that you look at the dispensing steps and you make SOPs for reducing dispensing errors. I can give an example that one we noted when we are having medicines that look very much alike, or they have dosing like 0.1 micrograms, that we wrote a chart that when you're dispensing medicine, make sure that the prescription has all these items clearly indicated: the patient name, the pharmacy that is dispensing, the dose, and the frequency of taking it, and not writing it as a mathematical equation, 1 times 3. You write it clearly, 1 every 8 hours, and you emphasize to the patient. I know there are a number of patients who still believe in 1 times 3, but what we find is easier. You can make the 1 times 3 practical. Like I say, 7 a.m., 3 p.m., and 11 or bedtime. So you can have that in place to reduce errors when you're, or even just having charts. So I want to hope that that has answered your question.
Okay, allow me to add. Elizabeth, just some background noise. Am I audible?
Yes, please continue.
Yes, you are.
I believe probably Elizabeth is just asking for simple steps in an SOP that can guide the dispensing processes, whether it's in a pharmacy, a community pharmacy, or in a hospital pharmacy. What would be outlined in that SOP? You need to guide. Step 1 should be receiving the prescription and validating it. Is the date okay? Is it an old prescription? Is it even valid? And checking the name of the patient, confirming, as Dorothy outlined earlier in the slides, we have patients with similar names. Yeah, so confirm if the patient had used the prescription. They could have picked someone else's prescription and come with it to the pharmacy. You then understand the prescription, interpret it, prepare the medication, label, check again if what you've done is correct, and then you document. We have registers in hospitals, so you record what you do. And again, you identify the patient correctly and dispense your medicine and cancel the patient. So in a nutshell, those are the key steps that should be followed when dispensing medication in any setup. Over.
Thank you. So as Imelda looks at the other question, there's the concern I think we've addressed. What's the Pharmacy and Poisons Board regarding look-alike, sound-alike packaging? And this we've kept on raising. Anytime we're in a forum with the Pharmacy and Poisons Board, we raise the issue because they're the ones who register these products. We are hoping that they will come up with solution. I was happy to see one of the local companies where we've kept on complaining about their products looking so the same. And now with the new products that they have been releasing, they've been making an effort to at least find a way to make it a bit more clear to distinguish. So we are seeing slowly they are listening. So I think we should not give up asking. And I think as we are getting to, I see time is fast spent, but I can see there's a question about verbal prescription. Who is supposed to be responsible? In our facility, we put up a system that if there's going to be a verbal order, you need to add a sticker that this prescription was a verbal order and that you must have it confirmed or countersigned within 24 hours, that an actual written prescription comes in place. Thank you.
Thank you very much for the very lively discussion that we've had. We'd like to just have the quiz, the post quiz. Habil, if you could load that, please.
So as that quiz is being loaded, I want to thank Dr. Nath. And actually, he usually has quite a lot of resources that it's also good to discourage unnecessary abbreviations because those are a risk for errors. So thank you, Nath, for your contribution.
We'd appreciate just if you can quickly answer the 3 questions now that we have better clarity. Thank you, those who have already started. Let's have more people, please.
accidental injury due to medical care. So a number of you at least have gotten that. I'm seeing 32%. The others who, there's one which very close, preventing all harm. Here, the trick here is all harm while in the process of delivering medical care and medication use. So we want to ensure freedom from accidental injury. Sometimes we can't avoid the harm. Then the question for what is the key step of ensuring medication safety? All the above are key steps. If you remember the 5 steps that Clarice took us through, we had step 1, appropriate prescribing and risk assessment, step 2, medication review, step 3, dispensing, preparation and administration, step 4 was patient communication and patient engagement, and step 5 was medication reconciliation and care transition. So all the above, and I can see 88% got this question right. Our last question was, a just culture in patient safety is best described as, and I'm glad a majority, 64% have answered correctly, that it is both making sure the healthcare workers are not victimized when errors occur, and also having a shared accountability of systems designed and responding to employees fairly. Maybe this might have been a trick question for about, this was probably a trick question for a few of those who joined us, but I'm glad that definitely learning has taken place. Thank you.
Thank you very much to all who participated, and thank you very much, Dr. Ayuak. All right, we now are coming to the end of our session. We will be able to advise on the date of the next session. We will share this, and you'll be all be advised in good time. We would like you to advise us of any topics that you'd like us to address, not just on patient safety or medication safety, but any other topics that you'd like us to address, and we will be able to see assess the numbers that want these topics, and we can then have them addressed. And so we come to the end of our session for today. It really has been a pleasure having you this evening. We know Friday evenings sometimes are furahi days, and so we appreciate your having made the time, and we do thank you very, very much. But most of all, our biggest thank yous, Dr. Dorothy Ayuak, Dr. Clarice Ambale, and all the team that supported this, the team from HOPAC, the team from CDMS, and also our partners, RUFA, and Making More Health. Thank you very, very much. We will be able to communicate further. I think for now, if you could just switch on your videos so that we can give a very big clap and for today. Unmute yourself so that we can hear your clap. Okay. Thank you very, very much.